All right, so I think everyone knows me, but Jessica, I am a student physical therapist with South College, and I get to talk about my favorite topic, diversity, equity, and inclusion. I'm very, very passionate about it. If you've not already had conversations with me, you will learn how much I love it today. But we're going to tie it into specifically where we are being in the outpatient physical therapy setting. So the boring stuff will knock out just the definitions really quick. Diversity, everyone probably has an idea of what diversity is in their head. And the textbook definition is that condition of having or being composed at differing elements, so just variety. In the social context, though, that means people of different races, ethnicities, gender, sexual orientation, socioeconomic status, religious beliefs, language, and geographical origin. So it's not just tied down to, I think people tend to boil it down to race and ethnicity a lot. And having a diverse community is one where all of those people that I mentioned before can come into a space and coexist. So in the clinical setting, how we apply it, it's going to start with diverse hiring practices. So just hiring individuals with a high variety of backgrounds. By doing that, we create an environment where every patient who walks through our doors gets the opportunity to see themselves in our spaces and within our practice. And it goes, again, just beyond race and ethnicity. So this is going to be encompassing people of different gender identities, sexual identities, age, body types, ability levels, as well as cultural backgrounds. And then with PT in particular, the challenge is it kind of boils down to admissions processes, because right now, healthcare in general doesn't really have very holistic admissions processes. A lot of the things that have to happen for the admissions process almost cut individuals off before they get a chance to start. So cost of GRE testing, the cost of just applying for schools. You have people who are like, oh yeah, I applied to 6 to 8 schools. That's wonderful if you can afford that, but not everyone has that opportunity. And so if I don't have the opportunity to apply to that many schools or to retake the GRE 4 or 5 times because I can't afford to, it limits my ability to even apply in the first place. A lot of schools don't do interviews, and so interviews can go one of two ways. It can either be where they can see you and they can kind of see your passion, really get to know you and speak to you holistically, or if that individual maybe has a bias, they see you and it kind of shuts them off to you in admission. So it can go both ways. But what we can do, because we can't really change the admissions process, not from where we are right now, but what we can do right now is outreach. So attending and speaking engagements, career days at schools, middle and high schools, we can reach those future PTs of tomorrow. I think this area is really interesting because you have pre-PT programs in the schools. I would say, though, something that's been interesting to me is I feel like if we were to go to those schools and you look, I don't know how diverse that student body is to begin with in that. And so that means that we need to step up even further and go outside of our immediate bubbles, going into different areas of our city, going to rec leagues, going to YMCAs, and things like that, where you have a greater outreach to different kids who don't even know that PT or healthcare in general is an option as a career choice. Equity is the E in DEI, and so it's defined as the quality of being fair and impartial. The most important thing, though, if you don't take away anything else from this slide, is that equity is not the same as equality, because equality dictates that everyone gets the same thing regardless of their need. Equity dictates that we see the individual's needs and we meet them where they're at. So I love this graphic because you see these 3 individuals, and on the left side of that image, they all get the same thing. They each get a box, and they are equal in that sense, right? So they each have that box there. The taller individual, he didn't really need it in the first place. The shorter individual, she can see, but she's kind of having to tiptoe a little bit. And then the individual in a wheelchair, they have the box, same as the other 2, but what are they going to do with it? Equity would dictate, I see these people as individuals and I adjust what their needs are. We do it with our patients all the time. So the taller individual didn't really need it. They can see perfectly fine in this image. And then you have the shorter individual, and she has 2 boxes. Now she can see comfortably, and then our individual in a wheelchair gets a ramp. And all of them now have equity, and they can all see the game. So if we think of it here in a PT setting, if you had 2 patients, both with non-specific low back pain, one's high school, football player, the other one is, 45-year-old male who's been really sedentary over the past year, dealing with COVID, lost his job, and hasn't really been moving. I don't think that anyone in here would assume that both of those 2 individuals would get better in the exact same amount of time with the exact same exercises, because that would be equality, but it wouldn't be equity. So it's that it depends. We need to treat people where they are and meet them. So in our clinical setting, we want to create an equitable environment by taking into account the patient's needs individually. So one patient that I had, she had congenital hand deformities. So certain things that we do exercise-wise, we need to modify, what I'm using for her to hold. She's the one who mentioned to me in the bathrooms how the stalls, she has a hard time turning the knobs in the stalls, and the sliders would be easier. And she also pointed out to me that the hooks are all the same height, and she was having trouble because when she initially came in, it was her shoulder, and she's like, I can't reach up there, and she's in the handicap stall, versus actually having the hooks where someone who has maybe a shoulder issue or who's in a wheelchair, because if they're in a wheelchair, they're certainly not reaching way up high where all of the hooks are on the top of the doors. Utilizing language services when needed. There are free resources. I know it can be harder in a smaller practice to do that, but the top icon is the Reverso Contexto app. It is free. Pop it on your phone. You can translate full sentences, forward, backwards, multiple languages, and it's one of the most accurate ones. And then the bottom icon is the Translate app that's on iPhone. So there are opportunities there. Other things in, having items like bariatric wheelchairs, walkers, bariatric gait belts, because every now and then, it may not be every patient, but we might have people who need that resource. And that ties into inclusion. So the practice or policy of providing equal access and opportunities to resources for people who might otherwise be excluded or marginalized. I really like this quote, because it says, diversity is the mix, inclusion is making the mix work. And so by doing our best to meet people where they are and meeting their needs, we're making this diverse community work. And it doesn't mean that we're going to meet every single need for every single person, and it's okay if we don't do that, but as long as we're trying to actively do it is the goal. So again, in the clinical setting, being inclusive means creating a space where individuals of all walks of life feel safe and able to be themselves. This does not mean allowing hateful or harmful language and actions from patients or employees at the expense of others. I know sometimes people don't come here just to say hello. They're coming because they're not feeling well. And so sometimes patients can lash out and not be the kindest, but it's because they're not feeling well. But we should still be able to be professional about it. And if they are saying harmful or hurtful things to coworkers, employees in a disparaging way, especially based on something related to DEI, we really want to correct that. One of my professors, I loved it, which she said, if you don't, they think you agree with them, in all honesty. So that is something to just kind of think on there. And so one example that Angelica shared with me, and I don't think that the patient meant any harm by it, but it ties into our micro versus macroaggressions. We'll get to it. But inclusivity for her, she was talking to her and said that she looked just like Gabby. And Angelica corrected her, was like, no, just I'm Angelica. And she, instead of using Angelica's name, called her other Gabby, which isn't the kindest thing. Angelica corrected her. No, my name is Angelica. I'm my own person. And she did a great job with it. I don't think any therapist heard that, and that was told to me afterwards, which thank you for sharing that. But that's an opportunity. If as a therapist you hear that, like, all right, we can have a private conversation about it. Because what if we had a patient, one, she did not deserve that as an individual, but two, what if we had another patient in here of Asian descent who hears this patient speaking to Angelica in a way where she's like, oh, well, you guys look the same anyway. It's not the most comfy thing. And then that patient may no longer feel comfortable being here. So moving into, I should have switched my slides. Health disparities and inclusion. So with health disparities, this is just going to be that burden of disease, injury, violence, and trying to get to those opportunities for optimal health. Some of the disparities that we see in the outpatient physical therapy setting are going to be insurance and appointment availability, transportation, being able to get here. So, a lot of times we definitely want to see some patients when it's appropriate twice a week, but sometimes that might not be feasible for them from a standpoint of taking off of work, from a standpoint of transportation. And it's easy to sometimes want to say, oh, they don't value what we do here. That's not necessarily the case. People sometimes have to make difficult choices, and it's not that they don't value their health or that they don't value what we as PTs can provide. They're just having to make a choice. Food insecurity is another one. So we often think of a fast food diet. We know sugars, processed foods, all of those things increase inflammation, hinder healing sometimes, or delay it. And so we want to educate our patients as far as those slight modifications that we can make, but we also want to do it in a way where they understand that we're coming from a place of love and caring, and that it's not a place of judgment, and understanding that sometimes they cannot make those modifications. If I am a single mother of 3 and I have to go to the grocery store, I'm going to choose the bread and peanut butter and jelly because I can feed my kids for a whole week, versus the 1 carton of strawberries that's more expensive than all 3 of those things. I'm going to choose the Lunchables because they're quick and I know that they will feel fed. So we can't place judgment and say, oh, they just don't want to change their diet. They, again, may not have the means or opportunity to do so. Another thing, it's not necessarily food insecurity, but one thing that's really important to me too is noting that cultural food differences, just because a food is cultured does not make it inherently unhealthy. So things like, I think one of my professors, we were talking about what we were eating, and I was like, oh, I'm making ramen today, and I have my Spam and this and that, and they're like, oh, you do the healthy version, and I'm like, well, wait, because it's not inherently unhealthy. So we need to understand that people come from different backgrounds, and foods that you hold memories for in your life that are special to you at events, they have their own versions of those as well. And it doesn't necessarily mean that theirs are less healthy than the ones that we hold. Access to recreational facilities. So after a patient leaves here, are they going to have the opportunity or means to go to a gym, to get a gym membership? Those are expensive. Are they going to have the means to purchase equipment that they need to do these things at home? So if you really get to know your patient and understand where they're at, we can get really creative and offer versions of those exercises where they can do things with body weight, or they can do things with everyday household items, so that they don't necessarily feel bad or are more likely to go ahead and continue those exercises. Because if they're like, well, I can't afford it anyway, might as well not do it. But if you offer them an alternative way to do the same thing, they may be more likely to continue and stay healthy. Language barriers we talked about, and then just a little note, unfortunately in this country, healthcare is a luxury, so we do need to remember that. With concordant and discordant healthcare, that just means that an individual's provider is similar to them in 2 or more of the ways of age, race, ethnicity, language, belief systems, gender, all of those things, socioeconomic status. And discordant is obviously the opposite. There's been research, and it just shows that patients are more likely to experience better health outcomes when they are treated by a concordant provider. This doesn't mean that you can't treat someone who is not concordant with you. All that means is, as a provider, if you see that there are differences that you're not quite understanding, that you do the footwork and you research, that you find a way to meet that person where they are, or where ways to understand where they're coming from culturally. And so just having a better understanding of all of those things that they may experience. You won't understand it fully because you're not physically experiencing it, but you can try, you can read, you can educate yourself. There's so many ways to do that. I have a patient right now who she shared with me that I am the first, well, she's a Black woman, and I am the first Black provider, even as a student physical therapist, that she's ever had in PT. She's in her 60s, and she also just got her very first Black primary care physician. And she said that with her new primary care doctor, she feels heard. Her new primary care doctor is able to say, okay, I know that you like to cook like greens this way. Have you tried this substitution? And it's these little things, these cultural experiences that we share. I've had conversations with her about like, all right, we're getting back into the gym, and she's like, cool, what do you do with your hair? Because I don't want to have to do my hair every day when I'm sweating it out. So little things like that I can share in. It doesn't, again, mean that I can't treat someone who I'm not technically concordant with, or that anyone else in here couldn't treat her. It's just understanding those slight differences, and that they're going to be there, and that's okay. Micro versus macroaggressions, talked about mentioning that one. So I just want you to think of, if you have trouble understanding what the difference is between the two, think of a microaggression as a paper cut. It's tiny, kind of stings a little bit, we can move on. A macroaggression is just a straight punch to the face. It is usually done with ill intent, and it's usually a result of unchecked bias, racism, xenophobia, homophobia, sizeism, and ableism. Microaggressions can sometimes be unintentional, but it's important to know that the intention doesn't matter. It doesn't matter if you meant well. When it comes to microaggressions, it's the impact that does. So that patient who said, oh, you guys look the same, she may not have meant any ill intent. That impact that had is a little harsh. One of my professors, when I first started school, and the very first time I went to lab, I changed my hair a lot, as you all know, and I did box braids, and he was thoroughly confused because my picture on my student ID badge, short curls, and he prides himself on being able to get all of the students' names because he was the student liaison, and he knew every single person's name, and I threw him off, me and a couple other girls who did our hair that way. And while I was talking to some of my fellow students, he came over and he goes, yeah, she just, she confused me. And he grabbed a handful of my braids and like just picked them up. And that may seem really small, but Black hair, or the history of hair in Black culture, it's very significant. And it took me 3 days to speak to this man because I was livid. And I know that his intention was not bad. He genuinely had no clue. He came from Argentina. He had not seen a Black person until he moved to the United States. He genuinely had no point of reference. And I cannot fault someone for ignorance. So, and ignorance, again, isn't a bad thing. It just means you don't know. And so you learn. And he did such a good job with educating himself after the fact. And after we had that conversation, and I've had several conversations with him since, and we're actually very close. And so he listened when I said that impact was harmful, even though his intention necessarily wasn't. And so when you do those things, it's not it's not some irredeemable thing. It's simple. Like I've misgendered people if I've heard their pronouns, but my eyeballs are seeing them present physically in one way, and I'm saying, okay, my eyes say they look female, but their pronouns are he, or he, him, or they, them, and I say it, and I say, I apologize, I'm going to correct it. If I just keep going and I'm not doing the work to do that, that's a microaggression. That's having a poor impact on them. So now, after that heaviness, we're going to play a game. Little Pikachu. So with this one, it's just face your bias. I'm going to show some images, You do not have to say them out loud. I genuinely just want you to think of like the first 3 things that come into your mind, reflect on them, and this, I mean, some of the things may be great and some of them may be like, oh, that's interesting. So, I'm just gonna show it and then just think. So first individual, it's kind of hard to see, sorry. Before I go to the next slide, I just want to talk about a few of these photos. This is Tamara Walcott, and she's hard to see, so I apologize. She is an amazing power lifter, like holds a record now. She just deadlifted like 600 and something pounds, like clean, raw, no grips, nothing. But if someone maybe saw her on the street, she's like 5'8", she's between 260 and 280, they might look at her and say, oh, this woman is obese, and not realize she is, I mean, incredibly strong. She's an athlete. She goes to the doctor's office and they look at her BMI chart, they're gonna be like, oh, you should lose weight. But she's so incredibly healthy, and she's lost over 200 pounds, but she's worked really, really hard to be where she is right now. The ladies in the top middle, those are all trans women, actresses, making waves in the industry. And I just wanted to show just their beauty. Next ones. So again, I just want to point out a couple of things here. So this young woman, she is actually on this side of the image in the midst of a battle with an eating disorder, struggling with anorexia nervosa. And then on this side, she is recovering. And some people might glance at it and say, oh man, she's so skinny. Like if they only saw that left side, and they may not realize what she's struggling with. And on the opposite side, you see these young men here who are heavier, and some people might look at them and say, oh my goodness, what's their parents feeding them? Look at that, they definitely don't eat McDonald's. And what are those biases that we have if we see a child come in who is overweight or obese? And I believe the gentleman up here, the ability level, I think when I first saw that picture, and I think it might be the background or just my bias maybe, the first thing I thought was, oh man, he must be depressed, because I see multiple limb loss, facial trauma, and so those different things. So what are we seeing? Like if I see that patient and they come in, am I going to immediately feel sorry for them? He might be absolutely happy and thrilled, but what do my biases have? If you see a patient come in and they have fabulous makeup, I wish I could do my face like that, what would be your bias if you saw someone who came in and his pronouns are he, him, and he came in looking wonderful? Could you handle maybe your older patients seeing him and staring or making him feel uncomfortable? How would you handle that as a provider? So how to fight your own bias. Harvard has a free quiz linked there. It's amazing. It has things based on body type, age, all sorts of things, race, And it's a really interesting test to take there. I don't know why it's only showing that. And then just educate yourself. So if you find an area in which that you have an implicit bias, research. Find the ways to fight those biases. Do not rely on individuals from the marginalized group to do the work for you. Google is free. And if you do the work and you still have questions, or you have someone that you trust and can talk to, ask them if they're comfortable with it. And then remember that bias is not a bad word. It is a 4-letter word, but it is not a bad word. We all have implicit biases. It's just when we refuse to acknowledge them and face them that they become an issue. Just some quick clinical pearls. A resource that is amazing, it's called Mind the Gap. It's written by a medical student, and he shows different medical issues on brown and black skin. One thing, in PT a lot, you're looking for like cyanosis, or what does blanching look like on brown skin compared to lighter skin. Pulse oximetry, it has been known for a long time that it does not read well on black and brown skin. It's actually very inaccurate, and it just has come to more light with COVID and the realization that a lot of black and brown individuals are struggling with long COVID a lot worse. And there's also some things with tests and measures, or those ranges as far as lung capacity. Yes, normative values, where black and brown patients, their normative values for their lungs, they are allowed to get a lot worse as far as the normative values go. So they're struggling with long COVID more.
Is it the same with Apple Watches too, with the pulse ox and stuff? Do you know?
Possibly. Yeah. On the bottom right, I just wanted to show this because one of my professors used it in a child abuse thing, and I had to correct her. That is a birthmark. It is called slate gray nevi. It is brown. It's like blue, purple, what have you, sometimes greenish. Can be all across the buttock, up the back, but in several instances, I've even seen on PT forums where, PTs are like, oh, I saw this thing, should I report them to CPS? And it turns out it's this birthmark. So I wanted to show it because in case that comes up, if you're not familiar with it or if you've never seen it before, I can see that it's one of the telltale signs. It's uniform color all the way down. It's not different stages of healing where a bruise would be. Really irregular shaped. My brother had it, and I remember as a kid, the first thing my mom would always tell any doctor that we went to that looked at him, he has a birthmark on his back, because they didn't have any point of reference. And then on the bottom left here, those individuals are all wearing chest binders. So you may find this in non-binary individuals or people who are maybe trans male wearing chest binders. They act as like a solid back brace, and they just, bind the breast tissue so that they can just feel more themselves. I had a professor who had a patient who was wearing one for years prior to top surgery, and then they got top surgery, and then all of a sudden their back was just in so much pain, and she realized it was because they had been wearing a chest binder for so long. And just take home message, at the end of the day, our job is to provide the best care for our patients, so we cannot be complacent in our assumptions that everyone already feels included and safe in our space. We need to actively work towards that. And we can accomplish this by facing our biases head on, educating ourselves in the areas that we fall short, and actively challenging ourselves and the biases of others. So, and I love this from Rob Tillman, change doesn't happen overnight, attitudes can happen overnight, mindsets take a bit longer to change.